You know, the advantage of being a moderator for a session like this is not only do you hear a trilogy of incredible talks, but you don't have to do anything because these three people stayed exactly on time, in case you were noticing. And I guess, John, I would say, you know, as I mentioned before, 45 years ago we kind of copied the grand plan of Medicare, and you have 25 more years of experience in England NHS than we do. And it seems apparent to me, every time I hear from someone from England NHS, it gives us a distinct opportunity to look into our future to a certain extent, despite the fact that the problems that you have right now are almost exactly the same as the ones that we do. And I guess it's pretty easy to see why you were chosen to be the man. Okay, you three, you don't get off that easy. Up you go. I'm not sure how we're going to do this right now because it's unrehearsed, usually the best, unplugged. But certainly, I'm sure there's things that are on your minds, and not sure what format we're going to use. Kate, what format are we using for questions and answers? I hope we can, are we passing around a mic, or what's the game plan? Yep, okay, good. Let me just get something started, and at serious risk to myself, just comment on a few of the things that I heard from each of you, if I might. You know, you're like our own rock star, man. There he is, our own rock star in this field. And if you were listening to him, I think he's trying to issue a wake-up call to us. Hurry up and start. It's time we started measuring it, incorporating it into our whole thinking, our trajectory of care, and what have you. It's not up to the patients to get sick on our terms. Beautiful. And Zurich, you know, what I took out of your talk was the extent to which you have properly thought through and actually gotten on with connecting health and social care as a part of the same continuum. We continue to struggle with that. If you go to most Canadian provinces, as I said to a few people yesterday, it's like the tide. Centralization, decentralization, the tide comes in, goes out, comes in, goes out. And so for health and social care, just look across the country. Sometimes the ministries get combined, sometimes they get separate, but we have never had a comprehensive way of putting them together in the way that you've thought through it. And may I also say, the way that you're exploiting technology, let technology be the slave, not the master. I think you have shown us the way. And John, one nudge at a time. Yeah, and you know, I'm surprised. I actually thought you had a national strategy for this, so that blows my first question. What's your advice to Canada on its national strategy? I'm still going to ask it anyway, but you said a few things that stuck with me. I'm still me. For patients in this room, or families of patients in this room, that statement, I am still me, I know, must really resonate with you. The operation went well, but the patient died. Focus on the person, not the disease. So you can't get better three talks than that. I just wonder if you have things that you've heard from each other that either you want to violently agree with or take issue with. Because let's face it, not everything Kez says is necessarily entirely and always true. And each one of us have our own approach and thoughts to this. So be not necessarily critical, but what do you think of what you heard from Ken, from Hans Zurich, and John? Comment, please. Grab a mic. You got it, actually, John, so you can start.
I'm happy to pass it on.
Turn around and let someone start. Is it good? Yeah, live? Go ahead.
Just going to say, I could see when I said that we haven't got a national strategy. Certainly, John and Tom, that I could see you both look down, and in a sense, I think that people are looking for an easy answer, and there really isn't an easy answer. I think we're really now in the world of complexity. I don't think it's possible to dictate from a centre what the right responses should be. that there is an element in which the way we're working in NHS England is so-called permissive way of working. We're trying to come up with the right tools and the right sort of instruments that would enable people to move in the right direction, but we're not really telling them what to do. And I think we learned that because those of you who had some familiarity with the English Health Service will know that roughly 15 years ago we had a thing called a National Strategic Framework for Older People that was incredibly ambitious, and it was supposed that this word transform gets used a lot, doesn't it? It was supposed to transform the care of older people in the English Health Service, and it didn't at all. So I think we've been very put off having national plans and recognising the complexity of what we have to do. What I took from Hans actually was, Hans-Erik, was that you can use different tools, but in a sense it is fairly decentralised in the way that you've been doing things. So that would be my rebuttal. Is it as decentralised as you're describing?
I think in Denmark we don't have an agenda on frailty, as you could also see from my presentation. And I think the reason is that the focus of the transformation is actually to implement a patient-centered healthcare, and that includes any kind of patient being aware of their needs, making the optimal plan and coordination in an integrated care setting. On John's question about being decentralized, definitely, even though we are a one-entity healthcare system, we are struggling with the barriers and between DPs and municipalities and regions. So definitely, we have not come to the end of our journey. We are making progress towards patient-centered healthcare, making it a reality, but we still have a long way to go. And some of the issues we are struggling with is definitely that the current way we have organized our healthcare system, it has to change, and it's not changing as rapidly as we could want to. One of the big-scale telehealth projects, their biggest problem was not the technology. It was not the patient. It was to introduce those new roles you need to have between municipalities and DPs and specialists and between hospitals to make patient-centered support of COPD patients in their own home a reality.
Ken, doing a national strategy, would it change anything for you whatsoever?
Not if other strategies have anything to go by. I mean, you know, I'm more of the persuasion which says, "Let 1,000 flowers blossom," and then pick the best ones. So I'm not sure in what a frailty strategy would consist that could bring about meaningful change. First of all, we've got the big issue that is it really a federal responsibility? Do we have national anything, and so on and so on. And the second thing is that the tendency will be to get agreement on the most trivial things or on the most banal things, because that's what you can get agreement on. So for example, prevention. I heard 3 different takes on this. I'm skeptical about a big agenda that you can prevent frailty. I think you can compress it. I think you can reduce the area under the curve of frailty for individuals. But the population push for this is going to be such that as we get more people over the age of 80, we're going to have much more frailty. That's a fact. And so I think that sometimes the prevention strategy is downplaying attention that we need on what's happening at the pointy end of care. I was very struck by the idea that we could go from what it was 90 hospitals to 40 or something like that. I think that is actually the right track. I think we'll look back on modern, large, complex teaching hospitals as being curiosities. So I think that we need to really have an agenda which promotes the reduction of harm and doing things that are harmful for frail older adults, and doing it in a way which is inevitable that will cause harm. And I think that as much as we need to screen for frailty and then not do bad things to people who are frail because they can't survive it, 10,000 times more, we need to be able to look at what is it we're doing right now that is causing such harm for frail older adults, right? No one right now is well served by malnourishment or sleep deprivation or failure to mobilize or not talking to families or not paying attention to pills. Mostly, though, we get away with it. But if we took the focus on frailty to reform the way we provide care so that we pay attention to those things, the whole level of care that we provide would be improved. So I would be skeptical about a strategy on frailty because I don't think that we can get the thinking around that we need in way to get the support for it that we need.
Please flail wildly if you want the mic, or otherwise go to that one right there. And while you go to that mic, if I might ask you to do that, Ken, you got off the hook pretty easy on that. You kind of were lukewarm on a national strategy. So let me make it a little easier for you. Do you think that we should institute mandatory annual home visits for people over the age of 75, given what you said about prevention, or didn't?
To the extent that the data permit it.
Okay, well, you can obviously not get a straight answer from Ken on really important questions like that, so maybe you want to ask him some questions, please, or anybody. What are your thoughts? So we got a lineup at the mic, and I can't see you because I got a light.
Hi.
So please start.
Hi. Thank you very much for a very interesting panel this morning. My question is for you, Dr. Rockwood. You talked a bit about frailty and the concept of frailty coming as a package, and that in our healthcare system, we often, I think, don't recognize that. We kind of deal with little box problems, and my little box is the ICU. And one of the problems I encounter is not so much the perception among healthcare providers that there are sort of little box problems as opposed to packages, although that is a problem. It's that I think sometimes family members and patients don't necessarily recognize, and very often I hear the words, age is just a number, et cetera, that there is the perception that, they're only in here with the one tiny problem, not the big package problem. As we engage and try to come up with a better healthcare system to task with this, what sort, I guess there's a tendency that this can be perceived by the population as a whole as like, I guess ageism, for want of a better word, or the concept that we are kind of painting people with one big brush. I guess my question is kind of half a question. What are ways that we can engage and get the message of it out there about frailty to the general public?
So briefly, there are two things. Like we've all been taught to do care planning from the first patient encounter, but we don't really know what that means. And from my standpoint, what it means is a reasonably detailed understanding of what the person looked like 2 weeks ago. And so the way that I do it is I say to the person, if I saw your dad 2 weeks ago and I saw him walk, did he walk like this or like this? So it's quick, it's easy, you can start. And then you get to understand what the person was like 2 weeks ago, and that's what your care plan is. So you say, so if we get your dad back to the point where he was 2 weeks ago, do you think you could take him home, for example? Would that be a state that he'd want to enjoy and live in and be happy with? And we have to be able to either do this ourselves or cause others to do it so that crucial conversation is had. So that's half of it. And the other half of it is we need to look at ICU practices and try and understand, are we in fact mobilizing people early? Are we in fact doing trials of spontaneous breathing? Are we in fact looking at a minimal sedation protocol and so on? And I think it's between those two we should be able to get the balance right from that. And that's where I think we need to go. The burden of it is that it sounds like common sense. The other burden is that we accept the ICU doc saying, well, we're too busy, we can't possibly do that. So we have complex things we get done all the time, CT, chest, abdomen, pelvis. What's the secret of that? Someone else does it. So if people really are too busy to understand the history, then let's have a protocol that allows that to be done. That would be the way I'd approach it.
Hi there. I'm Deborah Fells from Ryerson University, and for me this is a new area. I work mostly in the area of disabilities and assistive technology. And what I've noticed, a couple of things, I have two strands of question. The first is that in the world of disability, the models, there's the medical model, which is kind of what I'm seeing here, and the social model around how you look at people with disabilities. And then the other strand I have for you is I don't really see much place for the individual and their families. There was notions of patient-centered care, which means having access to your record, but I think it's much bigger than that. And there's, I don't see where the person actually has any input into what's going on here in either the models or in the solutions that are being had. So for example, I'm working on a system where the patient actually makes their own contribution to their records, which may solve some of these history problems. Some of it is a matter of how to filter that data, but I'm not sure where that fits within what's being said here. Thanks.
Okay, well, Tom, I'm happy to reply to that. I think you bang on the money, as they would say there, because that's where our health service is, I think jointly, is falling down. That in our primary care system, people are incredibly busy with the 7.5 or 10-minute consultations. And essentially what they're doing is they're providing a reactive care model. They're doing today's problems. And what we're trying to do now is to carve out some space in primary care for the individual to come up and be seen and noticed. And this is the whole agenda of care and support planning. Not a care plan, I have to say, which is something that healthcare professionals do to people. Care and support planning allows the space to occur for the real narrative of the individual person to be displayed and nurtured and really sort of rejoiced in, so that their issues can come to the fore. And the lady I showed you that was being corseted by 5 nice guidelines, that's the sort of lady that we're now looking to see, well, let's have a different approach. That in England we call this a more than medicine approach. It allows the person's story to come to the fore and to try and find different solutions to that person's predicament. Because often the predicament is a non-medical one. It's not issues to do with their diseases, it's to do with their life and their well-being. So I think we have to find some space in our busy health and social care systems for this to occur.
In Denmark, the clinicians have the same access to the electronic health record as patients, so they can use information from other part of the healthcare sector to prepare themselves. And I very much agree. It's about using those 10 minutes you have in a consultation to give more space to other things and look into the future. Also, the National eHealth Portal, they're actually starting to build now the personal health record where, as a patient and citizen, you can also give your own supplementary information to what's already in the EHR.
Yeah, I heard something different. I heard 3 people talking about ways to get the patient back at the center of things, way to get their preferences understood, way to get their function understood, way to get them to interact with their families. In the gerontological world, we've lacerated ourselves for 30 years talking about the medical model versus the social model, and we clearly have to have models of care that focus on the integration of all of that information in terms of how it gets expressed. So you know, I think it's good to draw this to attention, but you'll probably find that we're in fundamental and wild agreement.
Next, please.
Okay, my name is Elise Maybe. I'm a patient advisor, and I'm on the Research Management Committee here. I have a technology background, so my question is for Hans Erik, and that is the EMR. Do you have one EMR for all of your people, or do you have one standard that EMR providers provide you? And how did you overcome this sort of problem with having sort of multiple vendors and getting people all online, if that was the issue?
When the Medcom project started to establish the National Health Data Network, they also started driving the adoption of EMRs at DPs, and there was even seed money going with it to the DP, so they would get a sum of money to implement the EMR, because that was a prerequisite for being able to distribute the data in the in the health data network. In the beginning, we had around 15 vendors in this field in Denmark, and that was an issue because only the top 5 would make the necessary investment unless you had to push them, and it delayed the project. Today, I think we have 3 or 4 that share the Danish market. So it's definitely not one system in EMRs. And by the way, there's now 100% EMR coverage at the Danish DPs. It's not one system for all. It's not one system for all the EHRs. In the hospital, we have 3 vendors. What we have done is that we have developed an architecture to replicate data from different systems into different repositories. And that has been a very powerful strategy, because that allowed us to just add another repository when we start using telemedicine to hold all the data from the devices. And by the way, it's a trend that the other Scandinavian countries are looking into. I know Sweden, they're following the same ideas, and there's also interest from Norway and Finland to work together with Denmark in standardization.
Can't help but comment on that last one. Duncan, yesterday, your video, by the way, it was compelling, and I'm glad to see you here today. But, you know, you did comment about the record as a patient and as a caregiver. And, you know, this is a sticky wicket in large parts of this country where we get mixed up in our intentions and business policy, so we feel some abiding requirement to support multiple vendors in this. So I think, simply put, what Canada needs is one person, one record. We're vendor agnostic. Vendor agnostic. Doesn't matter who does that. But one person, one record. Not too many places are achieving it. Both of you are at least better than we are. Because we're on the bottom of all the OECD countries, right down there with the US of A. Unbelievable. Let's keep going.
Actually, your preface is handy, because I want to talk about Canada. So I'm Patty Rodney, and I'm an associate professor of nursing at UBC, and I'm also affiliated with the Center for Applied Ethics. And just wanted to start by saying how much I've really appreciated the morning's panel and the level of insight and hope, and very concrete as well as very strong philosophical ideas driving all of this. I think there was a consensus I heard that we don't want necessarily a blanket overarching one-size-fits-all strategy across the country. But I do want to make a plea that I know is understood by everybody in the room, but just to remind us that after ignoring the Romano Commission in 2002, where there was a serious attempt to do some harmonizing of home care, of looking at pharmaceutical support, looking at better approaches to acute care, including interdisciplinary clinics, healthcare reform in this country has been a bit of a patchwork quilt, with a great deal of fragmentation between the provinces and the federal government. And we've seen an erosion of both fiscal leadership as well as ideas leadership at federal levels. And the provinces have done, there's of course a lot of strength in our system, but our weaknesses show up, I believe, most with the care of older adults. And so what we see are, for example, home care systems where the ability to be proactive about symptom management and to truly support families and their loved ones is increasingly difficult. For example, that in too many places, a home care nurse will be sent in for a very specific task and funded on that basis, not on the basis of the overall need of what's happening in the family. What we see in acute care are tremendously overstretched resources, with holding people in emergency departments, people who are older adults deemed do not resuscitate on general medical surgical areas, where the pace of work is so busy and fragmented that they are literally walked by. We also tend to see that the areas, what we know to be necessary in terms of the kind of supportive conversations for advanced care planning are really very difficult in our stress system. Those are just some episodes where we've got research evidence that this technology evaluation in the elderly project has helped to put forward. And I guess, I know that was a long-winded preamble, Tom, and I can see that you're getting ready to...
You got a question, Patty?
Yes. The question is, how, which is what I'm going to come to, how do we start to have conversations politically, in the best sense of the word, in the sense of a values-based commitment to healthcare, to start to actualize the promises that you've put forward? So it's a nice, easy question, Tom. Thank you.
Thank you. I'm glad I don't have to render the answer.
So I think it's important to lead with data. I think it's important to lead with examples of things that have worked, and then try and make the inference about what values drove that and build it from there. I think part of the issue of trying to do it from the top down is you either wind up being overly specific or banal. And I think this is an instance in which seeing things that have worked well and understanding what motivated that would go a long way.
So I'm going to step up now and actually be the moderator. We have 3 speakers. We have 5 minutes. Let's act accordingly. Joyce, you're next.
Well, I'm certainly going to make it brief because I hardly have a voice, so. But I'm Joyce Resin. I'm on the board of directors of TVN, and I'm motivated to come up and speak because I was really quite moved by the 3 presentations this morning, and I think there's a lot of learning there for us at the board of TVN in terms of our moving forward. What I want to ask maybe builds on some of the questions that have been asked before, and that's around the issue of empowerment. You've given us some really interesting examples of empowerment at the bedside, empowerment in terms of personal health. What can we learn from Denmark? What can we learn from the UK in terms of empowerment around decision making? Around that national strategy, how have you been able, can we learn something about how you have been listening or able to listen to the frail elderly in terms of policy making and decision making?
Snappy response, John?
I think if you want to learn a bit about this from an English perspective, go onto the National Voices website and have a look at the work that they've been doing. In NHS England, that work is the foundation for everything that we do, so that the user's voice is absolutely the heart of all the reconfigurations that we're doing. So I would suggest you have a look at National Voices.
Short comment from Denmark. The Danish version of HUK, that means the patient organizations, they're definitely very active. And a confirmation of that is, as I mentioned, that they're invited to the table with the Prime Minister to discuss how do we improve and handle the challenge of dementia and create patient-centered care in that area.
Thanks. Next question, please. Next to last.
Hi, I'm Erin. I'm a doctoral student at the University of Victoria, starting research with people with mental illness approaching end of life. I have a question for Mr. Henriksen. You talked about making rehab the responsibility of municipalities and to make it possible to reduce the length of stay in hospital. I'm wondering how that was resourced. So was the healthcare budget increased? Did municipalities have to bear the cost? Was money moved from a different care setting?
Sorry, I didn't get the whole question. Could you repeat it?
The essence was, how was it resourced?
Yes, yeah. So when the responsibility was shifted to the municipality, how did the municipality end up paying for that, for the rehab?
Yeah, it was a plan of the reform that the municipalities had to staff up to be able to offer rehabilitation. You also saw on my chart that we have more people working in social care than we have in the hospital sector. So they have been investing in this area to be able to offer these rehabilitation services and increase the number of employees.
But were there new resources applied at the district level, at the municipal level? Were there new financial resources put in for that?
Yeah, there were.
Which came from your taxation system?
Yeah. With the reform, municipalities could still have their own taxes, but had to agree on the level with the government. The health regions, they could not anymore have own taxes. They are depending on money from the government and the municipalities.
Thank you.
Thank
Last
you
question,
much.
please.
My name is Johanna Trimble, and I'm the public member on the Polypharmacy Risk Reduction Committee in British Columbia, steering committee, and also on the antipsychotics, call for less antipsychotics in residential care. And I'm wondering, in Denmark, how are you handling the issue of deprescribing?
Deprescribing, how are you handling that? Getting rid of prescribed drugs that people are on in polypharmacy?
When we implemented and really got the national overview of medication implemented, and it's now implemented to an extent as a patient I can see my medication, but also that all EHRs and EMRs, they replicate data about prescription, and prescription data is replicated back, so clinical professionals, they work in their own system. We had big issues, not so much with the technical solution, but when it went live, the hospitals, when they looked up the medication, they said, okay, the DPs have prescribed this medication, I think it's crap, I'm going to cancel it, and I'm going to make my own prescriptions. And when the patient got back to the DP said, what happened here? Because now every medication was transparent. So we had a big effort to actually tie the knots between hospitals and DP to ensure that when you go to hospital, medication is reviewed and they don't touch anything that is basically okay. And when you come back, there's an obligation from the DP to review medicine. So that process is actually removing a lot of hazardous and medicine which nobody knew were there, and the interactions which nobody knew were there. So we're in the process of drastically improving the quality of medication, and that also is benefiting elderly citizens tremendously.
Thank you.
Thank you.
Well, we're done, but I want you to do one last thing for me before we finish. What's the one statement you want to leave all of these folks with as they leave the room based on everything you've said so far today, or any message you want to leave? John, start with you.
I think that the world of frailty is really stimulating, interesting, and it's a tremendous field to work in.
And Zurich, thank you.
I think one of the experiences from Denmark has been to do the pilots, as you understand, get the good examples from research into testing it at a real life environment. When it works, then ensure that everybody implement, then you can make things change.
Frailty is here to stay. We have to learn how to not just live with it, but to embrace it.
Thank these people. Thank you.